Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have a 15-year-old female brought to the clinic by the mother for behavior issues. Mom states her daughter has been acting out since the school year started about 2 months ago. She seems much more impulsive and aggressive and has actually gotten into fights at school. At home, she is also constantly arguing with Mom and always has a grin on her face. Mom feels at times that she is in a world of her own. Mom says she thinks the patient is clumsy and drops things from her hands. Mom took her to a psychiatrist who started her on fluoxetine 2 weeks ago. On questioning the patient on her own, she says she is just annoyed by everyone. She admits she cannot focus and that her grades have fallen in school. She denies any drug use, any alcohol use, or sexual activity. She admits to feeling sad at times, especially since her grandmother was diagnosed with a brain tumor. She denies any suicidal ideation or feelings to harm others. Past medical history includes a hospitalization for a concussion about 2 years ago while she was playing basketball. Travel history, they went to the Wisconsin Dells 2 months ago. Allergies, there are no known drug allergies. Immunizations are up to date, including the HPV series that she got last year. Social history, lives at home with her parents and 12-year-old brother. Family history includes the mom who has lupus, the grandmother who is currently being treated for a brain tumor, and an aunt with a factor V Leiden deficiency. On physical exam, her temperature is 37.7, heart rate is 82, respiratory rate is 20, blood pressure is 108/72, height and weight are in the 25th percentile. In general, she is alert, awake, and cooperative, and in no distress. HE&T, pupils are normal, extralocular muscles are intact, the sclera have some questionable icterus, there's no papilledema. Tympanic membranes are normal, and the throat has no erythema. On neck exam, there are a few 1 centimeter cervical nodes bilaterally. Lungs are clear. Cardiac is regular rate and rhythm with a normal S1 and S2, but she does have a grade 2 out of 6 systolic ejection murmur at the left lower sternal border. Abdomen is benign. Extremities, there's no clubbing or cyanosis, no swelling, no erythema or warmth of the joints. Neural exam, there's no focal deficits, but she does appear to have a hand tremor. Deep tendon reflexes are 2+, and there are no cerebellar signs. On skin exam, there are no lesions and no jaundice noted. So to summarize our problem list, we have a 15-year-old female with behavior issues and behavioral changes. She has been dropping things. She has a history of a concussion about 2 years ago. There's a family history of lupus, a brain tumor, and factor V Leiden deficiency. On exam, she has questionable scleral icterus and does have a hand tremor, and she's been on fluoxetine with no improvement of her symptoms. So in this case, we have a 15-year-old girl coming in with behavior changes for the last 2 months. So let's go through a differential diagnosis of a 15-year-old girl with behavior changes. The first category that we have to think about in adolescence is some sort of substance abuse or ingestion or inhalation, some sort of toxic ingestion or result of some sort of toxin. So that would be the first category to think of. So we can put this down. So some sort of ingestion, inhalation, or other toxin exposure or substance abuse. These are things you have to think about in any adolescent patient coming in with behavior changes. So that's very high on the differential. So after that, then we can think about other causes. And at this age and in general, when you have behavior changes, you have to think about some sort of neurologic type of process, maybe some sort of encephalitis. So let's talk about some of those type of entities. So encephalitis is another consideration, and encephalitis many times is viral mediated. So especially in the summer months, you can have different arboviruses and other type of viruses that can give you encephalitis. And right now, in spring of 2020, you have to think about COVID-19 causing encephalitis as well. So that's a consideration for behavior changes, some sort of encephalitic process. In addition to that, another infectious process that can give you encephalitis is Lyme disease. In different parts of the U.S., Lyme disease is endemic in the upper Midwest, on the East Coast. Depending on different risk factors, then you might think about Lyme disease as a possible cause of encephalitis as well, causing behavior changes. And then if we continue on into other neuro type of causes, so this was encephalitis, but now let's think about other neurologic causes of behavior changes. So in adolescents, adolescent girls, you think about different demyelinating type of processes. So MS or multiple sclerosis is, I think, a consideration in this type of patient as well. And another entity causing demyelation is called ADEM, acute disseminated encephalomyelitis. This is basically where you have demyelination in the brain related to some sort of viral process. So it's kind of a post-viral type of demyelination that can occur. So thinking about demyelinating processes like multiple sclerosis or ADEM is another consideration as well. Other neurologic causes, you can think about some sort of trauma, head trauma. So she could have had a concussion and a post-concussive type of process, so concussion or brain contusion, something like that can cause you to have behavior changes. So I think that's something to consider as well. Then you could have some sort of bleed, so intracranial hemorrhage, a bleed or an infarct, a stroke, anything like that can also cause you to have behavior changes as well. So I think that's another possibility. Other things to consider would be like a tumor causing increased intracranial pressure, and a brain tumor causing to have behavioral changes. So depending on the location of the brain tumor, it can manifest in different ways with behavior changes and other neurologic focal deficits as well. And then we have mentioned bleeding, intracranial hemorrhage, but another possibility is that she could have an AVM, a arteriovenous malformation that has now ruptured and is causing bleeding. So that's kind of the intracranial hemorrhage, but it could be from different reasons. An AVM and that has ruptured could be another possibility as well. We mentioned the brain tumor itself causing behavior changes, but also, as we said, it can increase your intracranial pressure, and that can cause you to have that behavior changes. Other causes of some sort of hydrocephalus from an obstructive type of process or otherwise can also cause you to have behavior changes as well. So I think that's something to consider. Sometimes you can have different type of seizures, and seizure disorders can present with behavior changes and being post-ictal and other type of behavior changes. There's one particular type of seizure that maybe doesn't give you classic behavior changes, but does present in the adolescent age. That I think you really have to think about. And the typical story clinically and also on board exams and vignette that will come up is you have an adolescent, like a 15-year-old who has these kind of jerking type of movements, and you get the history of that first thing in the morning. When an adolescent female wakes up and has a certain type of seizure disorder that I'm thinking about, when she's getting up and she's kind of brushing her teeth, all of a sudden she has like a jerking movement and throws her toothbrush, or she's combing her hair or brushing her hair, and all of a sudden she has these twitches or jerking movements, and then kind of throws her toothbrush. So typically when you're kind of tired or sleepy and kind of groggy, you can have these jerking type of episodes and jerking type of movement. So that will be the classic vignette that will be presented on a board exam, but also clinically can present this way as well. So the one entity I'm thinking of is called JME, which is juvenile myoclonic epilepsy, and that commonly presents in this age group as an adolescent with these twitching movements or jerking movements, especially kind of in the morning or in the evening when you're kind of sleepy and you're brushing your teeth or you're combing your hair. So juvenile myoclonic epilepsy is another seizure entity that can present at this age, and maybe doesn't have the classic behavior changes, but it could be perceived as behavior changes because they seem to be, throwing things or clumsy and dropping things, and that could be something to consider as well. And then one other entity I think that is over on differential, kind of an encephalitis type of process or a neural type of process. It's called anti-NMDA receptor encephalitis. Anti-NMDA receptor encephalitis. So there's another entity that is considered kind of autoimmune or post-infectious, causes an encephalitis type of picture, and actually can present with a lot of different seizures and very difficult to control seizures. So anti-NMDA receptor encephalitis is another autoimmune type of process, post-viral, post-infectious type of process that can present with behavior changes and seizures and encephalitic type of a picture. So I think these are some of the things that you have to consider initially when a child about 15 years of age comes in with behavior changes. One of the early things is going to be some sort of ingestion, substance abuse, inhalation, things like that. Then other infectious causes like encephalitis. Then other causes of encephalitis or other neurologic type of processes are also something to consider in this age group. Then, and then there's other processes that you should start to think about and consider as well. And that would be related to endocrine type of processes or metabolic, right? So let's talk about metabolic type of processes. And this can cause you to have either seizures or other neurologic type of changes in metabolic or electrolyte type of imbalances, right? So different electrolyte metabolic type of processes and changes can cause you to have behavior changes. So anything related to glucose, right? So you can have DKA, so you can have hyperglycemia, and that can cause you to have encephalopathy and cerebral edema and behavior changes, right? Or you can actually be hypoglycemic, right? And that can cause you to have a lot of changes in your behavior as well. So sugar issues, hypoglycemia and hyperglycemia, a low sugar or a high sugar can also cause you to have these type of metabolic or electrolyte type of disturbances. And then there's different other electrolytes, so sodium issues, right? So you can have a low sodium or even a high sodium, and that can cause you to have changes in behavior. So if you have dehydration, or you have some other electrolyte imbalance, or if you have something like Addison's disease, and you have salt wasting, right? So that can cause you to have that. So if you have Addison's or adrenal issues, adrenal crisis or Addison's, that can affect your sodium and your hydration, and cause you to have different behavioral changes as well then, right? So any type of acidosis, whether it's metabolic acidosis or ketoacidosis, or some sort of lactic acidosis from dehydration, or any other inborn error of metabolism, so organic acidemias, and other amino acid defects that cause you to have acidosis, that can prompt electrolyte imbalances and behavioral changes as well then. As we continue the differential for metabolic and electrolyte type of issues, more kind of metabolic type of things, another entity to think about will be something like Wilson's disease, in which you have copper deposition, and that can present in this age range or even a little bit younger. And then another entity to consider would be some sort of mitochondrial type of issue, so mitochondrial defects. Can also give you behavioral changes as well then. So I think these are another couple of things to kind of consider, kind of metabolic or inborn errors or different electrolyte type of issues that can give you behavior changes. So I think this is something to consider on the differential here. And now as we move on to other type of categories in a 15-year-old girl. We can think about kind of related to substance abuse, and this category up here we can think about other psych type of issues, right? Other psychiatric type of type of causes of behavior changes in the 15-year-old adolescent then, right? So under psych type of things, you can think about, maybe she has depression, is having psychosis, right? So depression with psychosis, and that is causing her to have the behavior changes, right? So it could be that she has depression with psychosis, so that's something to think about as well. Or she could have bipolar disorder, and that's causing her to have a lot of behavior changes, kind of fluctuations in her mood and things. So that's there. Other type of things like schizophrenia or schizoaffective disorder, things like that, you can think about as well, or even personality disorders. So some sort of personality disorder that is coming out at this point. So she could have borderline personality or oppositional defiant disorder or antisocial personality disorder. So some sort of personality disorder that is causing her to have these behavior changes as well. And then we mentioned electrolyte imbalance, but it could be that she has some sort of eating disorder or anorexia or bulimia, and that's causing her to have electrolyte disturbances or overall behavior changes as well, right? So she could have some sort of eating disorder that might be causing her to have that as well. And then other things, a lot of times you have comorbid conditions, so even things like ADHD, learning disability, where you're getting frustrated in school and then you're acting out in school, acting out at home, so that's always a consideration as well. So ADHD or like a learning disability where she's getting frustrated in school and now is kind of acting out in school. So that's, I think, something to consider as well, ADHD and learning disability as well. And then the final category that we can talk about is autoimmune. So she's a 15-year-old girl. So I think autoimmune collagen vascular autoimmune type of things I think are very important to consider at this point as well. So she could just have a non-specific vasculitis for various causes, right? There's lots of different types of vasculitis type of processes that can cause you to have behavior changes, CNS involvement, electrolyte abnormalities from renal involvement. So there's a lot of different things that could be happening then. So as part of this, you always got to think about lupus and a complication of lupus, like a lupus cerebritis, can also present with encephalitis and behavioral type of changes. So lupus and the different complications of lupus can definitely cause you to have behavior changes as well, either primary CNS involvement, neurologic involvement, or other involvement from kidney involvement, electrolyte imbalance, hematologic involvement, and anemia, or maybe other autoimmune type of things like even thyroid type of issues, right? So we can put that in here as well. So thyroid, autoimmune thyroiditis, and other Hashimoto's thyroiditis and other thyroid issues where you have a high thyroid or a low thyroid, and that can start to affect your mood and your behavior as well. So that's something to consider in this category as well. And then another couple of entities that are kind of similarly related, and there's some discussion about whether these entities kind of, I guess, really exist or not. There's different opinions and schools of thought between ENT and infectious disease about these couple entities. It used to be called Pandas, which stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Strep. And now the more recent literature is calling it PANS, which stands for Pediatric Acute Onset Neuropsychiatric Syndrome. And both of these are related to an autoimmune response, and the thought is that a strep infection can sometimes maybe bring on some sort of autoimmune response and cause you to have neuropsychiatric type of manifestations, where you have worsening of ADHD symptoms, worsening of OCD symptoms, obsessive compulsive disorder symptoms, worsening of like tics, worsening of Tourette's, associated with an acute strep infection or recent strep infection. So there's a little bit of discussion about that whole process and between infectious disease specialists and ENT specialists, and what thoughts they have about these entities. But I think that's something that could still be considered and should be considered on a 15-year-old coming in with behavior changes as well. So this is the differential diagnosis that you would consider on a 15-year-old girl coming in with behavior changes. So it's quite a broad differential diagnosis that you really have to think about and kind of rule in and rule out. And then you have to start a workup to rule out some of the more emergent things and urgent diagnoses, and then start a workup for some of the other things that you might be considering on the differential. So let's see how this case unfolds with our patient as we start to work up to rule in and rule out some of these processes, and let's go through what the findings were and what the ultimate diagnosis is on this patient. So the workup on this patient was started, and there were some basic labs that were drawn. And the patient had CBC, which was normal, had electrolyte panel, which was essentially normal. The liver enzymes were a little bit elevated on the electrolyte panel, but the other electrolytes were totally normal. The patient had ANA and rheumatoid factor that came back negative. The patient also had a UA that was normal, and then had a spinal tap to rule out the encephalitis and the demyelinating processes, and that also came back normal as well. The patient had Lyme disease titers that were sent, and that was negative as well. So kind of the workup was not really showing a lot initially, other than some mildly elevated liver enzymes and kind of a transaminitis that was found on the labs. Otherwise, everything was kind of essentially normal at that point then. So the team decided to consult psychiatry to get their input, and psychiatry came by and thought that she had depression with some psychotic features, but did recommend further workup. And they recommended an MRI of the brain, and they also recommended a consult to ophthalmology. The MRI of the brain was done, and that was normal. It did not show any type of demyelinating process or bleed or any other type of acute changes or findings. And then the ophthalmology team came by and took a look at her, did a slit lamp exam, and kind of confirmed or started to help confirm the diagnosis on this patient. And the diagnosis was further than confirmed by other testing, but the initial eye exam showed Kaiser-Fleischer rings on the eye exam, suggestive of the disease process that we know is commonly associated with the Kaiser-Fleischer rings of possible Wilson's disease. So based on that, the patient had a ceruloplasmin level in the blood that came back low, and then also had copper levels in the urine tested, and urinary excretion of copper was elevated, and that was all suggested then of Wilson's disease, and she ultimately was given a diagnosis of Wilson's disease. So in this patient, who now we've diagnosed with Wilson's disease, let's go back and look at some of the history and exam that would be suggestive of Wilson's disease. So she's a 15-year-old girl with behavior changes and actually some neurologic findings. In Wilson's disease, up to 10% of patients with Wilson's disease will have some sort of psychiatric type of manifestation as their initial presentation, and about 35% of patients with Wilson's disease will have some neurologic manifestation of their initial presentation. So she had a little bit of both, because we have the psychiatric issues where she is having behavior changes, is getting more moody, getting more aggressive at school, but also has neurologic findings where mom gives a history that she's kind of clumsy and she drops things. So that would be one of the neurologic findings. And then on exam, she also had some questionable scleral icterus as well. So as we mentioned, her LFTs were a little bit elevated, and her bilirubin was just a little bit elevated. So that was suggesting the liver involvement of Wilson's disease. And then on exam, she also has a hand tremor that is noticed. And in Wilson's disease, an intention tremor of the hand is not uncommon in patients with Wilson's disease. So she had some of the clinical manifestations of Wilson's disease based on the history and the physical exam when you kind of look back on the history and the exam. And it's interesting, mom gives the history that she kind of has this grin on her face all the time, and that's actually a finding that you can see in Wilson's disease in a small percentage of patients, where they have this kind of uncontrollable grin as a result of some of their neurologic and or psychiatric manifestations then. So that was actually part of that process as well. Other things on the differential based on her history and her exam that we were thinking about, I think are important to consider, given the family history of lupus. So we had talked about lupus and vascular processes and autoimmune type of processes. There's a family history of a brain tumor, so that was on her differential diagnosis as well. And then there's a family history of factor V Leiden defect, which would cause you to have hypercoagulability, so some sort of infarct or stroke is something to consider as well. So those are all things in the history that were important to consider as part of a complete differential diagnosis on our patient. But again, ultimately she was diagnosed with Wilson's disease. And the treatment for Wilson's disease is chelation therapy to help with the copper deposition and minimize the copper deposition. So the treatment usually is a chelation. So one option is N-penicillamine that is traditionally used. There's a newer chelation therapy called trientine, which is another chelation agent that could be used as well. So chelation therapy is the mainstay of treatment to minimize copper deposition in the liver and in the brain and in the eyes and other parts of the body, and then monitoring for liver function and making sure that the patient doesn't go on to develop any type of liver failure and fibrosis and cirrhosis and needing any type of liver transplant. But the treatment basically is trying to prevent copper deposition and lifelong chelation therapy to minimize damage to the liver. So that's a brief overview of Wilson's disease. You can read more about Wilson's disease and get more details and read articles about Wilson's disease. But again, as part of the CRASH case and the CRASH course, my focus is more thinking through the patient and using clinical reasoning skills and analytical skills to come up with a broad differential diagnosis, and then based on the differential and based on the history and the exam to do a workup, and then based on your findings in the workup to be able to come up with the diagnosis on the patient. So that is a brief overview of the differential diagnosis of an adolescent girl coming with behavior changes, the things you have to consider in this broad differential diagnosis, and then your workup. And then our patient ultimately, like I said, had Wilson's disease and was treated for that. So hopefully this case was helpful in the thought process and the clinical reasoning that goes behind looking into behavioral changes in an adolescent female and the approach to that patient. And look forward to having you come back to view our next CRASH case.